Welcome to the Head and Neck Cancer 2020 video series, presented by St Vincent's Hospital Sydney, the Kinghorn Cancer Centre and St Vincent's Private Hospital Sydney. Innovations in Surgery with Susie Flynn.
Hello, I'm Julia McCrossan and welcome back to our second segment on innovations in surgery for head and neck cancer patients. And this is part of a series looking at innovations in treatment and care in order to improve survival, but equally importantly, quality of life to reduce side effects. You may have already heard our interview with ENT surgeon, Dr. Richard Gallagher, and he's talked about the robot, the transoral robotic surgery. Well, I'm now meeting another member of a multidisciplinary team working with head and neck cancer patients, and she has worked as a nurse coordinator. So let's meet her now. Susie, tell us what job you're doing right now. Can you introduce yourself and tell us your current job and then your past history, particularly with head and neck?
My name is Susie Flynn and currently I'm a CNC for Cancer Services and Palliative Care at St Vincent's Private.
And what's a CNC?
A clinical nurse consultant, so a specialist in their field. But previously, I've just recently started this role, but for the past 10 years, I've worked as a cancer care coordinator and on the surgical head and neck ward at St Vincent's Hospital.
And we were discussing earlier in this session on innovations in surgery how multidisciplinary teams are vital and how an expert nurse as a coordinator is crucial. I felt that as a patient. Can you explain it from the nurse point of view? What was your coordination role and how did it improve survival and quality of life for patients? Why should there be more nurses like you were?
Well, cancer care coordinator is basically the patient's point of contact throughout their whole cancer journey. So I would have met the patients, not met them physically, but spoken to them on the phone prior to them to coming to our multidisciplinary team meeting. So they would have known me as well as the surgeon. We're the two people that they would know or who they were meeting. And I would guide them through the whole meeting. And then I would guide them through their surgery, and then if they needed any care afterwards or any other treatment, such as radiotherapy, chemotherapy. I would have seen the patients every day post-surgery. So if they have any questions, as I said, I'm the big focal point of contact. I can get hold of anyone on the team very quickly for a patient while they're sitting in the bed or their family members are sitting beside them. And it's a very anxious time for the patient and the family, so you have to be very mindful of that, not just of the physical side effects the patients get, but also the emotional side of the emotional well-being of the patient and the mental health of the patient. With head and neck surgery, you can't really hide too much unless it's inside. If it's outside, it's quite visible.
I had radiation and chemo and I didn't have surgery, so I'm not as familiar with surgery. Can you imagine that some of the people watching this may have just got their diagnosis? Give us a sense of some of the emotional and physical challenges a patient can face and the improvements you've seen both in physical care and emotional support.
Depending on the surgery, obviously, Julie, it depends on the physical side effects post-surgery. A lot of people come back with a breathing tube called a tracheostomy, which is a breathing tube into a windpipe. That's only temporary, it's only in for a few days, but that can be quite distressing because people can't communicate. They have to write down, so they can't speak. Also, people come back with feeding tubes sometimes. It can be temporary, a nasogastric for a few days to let swelling reduce down, but also permanent tubes into the stomach called PEG tubes, feeding tubes, and these can be permanent. So people have to, get used to a different way of life post-surgery. Some of it can be long-term, some of it can be short-term. So it's just helping the patient along the way, and a lot of it is education, explaining, and letting them know that no question is, silly. All questions are relevant. And with the emotional side of things, it's people can have facial disfigurement, which can lead to depression, mental health. We have to look at everyone as a whole, not just one small part. They've had, their larynx removed or something, but you have to look at the patient holistically. And that's why I think innovations in recent years has been an excellent MDT, multidisciplinary team. So you work as a whole.
So explain again what an MDT is and why is that an innovation that's improved the life of the patient and their family?
Well, you're getting many specialists together in one room to discuss a patient's care, a patient's journey from start to completion. So you're getting specialists, ENT surgeons, plastic surgeons, then you're getting allied health, which is speech pathologists, social workers, dietitians, and you're getting nursing staff, cancer care coordinators, nurse practitioners, everyone in one room, everyone specialised in their own field, but we're all, one person can't do the job without the other one being there as well. It has to be everyone together. And I think that's another thing for patients, for survival as well, and for greater outcomes. If you have specialists in the one area looking after the patient, survival outcomes are better.
I think I should reveal to the audience that you were my nurse coordinator when I was a patient. And how I remember you is that you gave me your telephone number and that if I needed anything, either I or my partner Melissa would ring you, and amazingly quickly a dentist would ring me or a doctor would ring me or a speech pathologist would ring me. You seem to have the respect of your team and they would move quickly when you needed them to contact someone. Is that a fair summary?
Yes, that is a fair summary. And I suppose that is our job, to know when to contact a consultant, when to contact someone, and have the referrals appropriately done. You nearly preempt when the patient needs one. You're already thinking maybe 2 steps ahead of them of when they need it, and I suppose that comes with time and experience in the role as well.
And apart from the team, is there any other improvements, innovations or changes that you think have made it better for this head and neck patient?
Well, I know Richard has spoke about the robot, but that has been a big change for patients.
What do you see as a nurse in terms of the difference for a patient?
Well, it's less invasive, less time under anaesthetic. Their function is a lot better with their speech and swallow post the robot. You know, they can be a bit swollen for a couple of days, but that goes down quite quickly. And another big thing is their length of stay in hospital is reduced, which is good first because not all of our patients are from metropolitan area. We have a lot of regional patients and sometimes they can only travel up on their own. So to be in a big new city, you know, some of them have never been in cities before. It's, you know, it's nice to have, say, you're going to be in for 3-4 days instead of 2 weeks.
Are there any other improvements we need for rural and remote patients? Because you have met a lot of those patients.
I have met a lot of those patients, and I suppose with my job as well, I coordinate when they go back to rural areas. I try to link them in with a nurse that's based there, but not all areas have specialist nurses, have care coordinators, unfortunately. Not like other tumour streams like cancer, prostate. I would love to see head and neck specialist nurses all around Australia in every state.
Why?
Because I think it will be better for their outcomes, for their long-term side effects, that they have a specialist nurse in their region, that can be their point of contact. They still will have a point of contact where they've been treated in the centre, but I think it's important to have someone closer to home that they can ring, and then that person can ring, say, if it was me, you know, and we can discuss, and I can discuss it with their team here. Also, I think for the specialist nurses, it would be great if we had them around Australia in every state, that they could even link in with telehealth, which is a whole new thing at the moment now due to COVID, but link into our multidisciplinary team meeting and see how it's run and get a sense of that. You know.
And we've got people watching this from New Zealand as well, because many of the colleges, of course, include Australia and New Zealand in them. You mentioned explaining again and again and again, and can I just say as a patient, if there's one thing I'll always be amazed at is from the moment I was told I had stage 4 cancer, I lost about at least 50% of my cognitive function. I couldn't remember anything anyone was saying to me. I had trouble understanding, and then once you started giving me pain relief, the opioids, so I guess what I'm trying to say is the role of the nurse coordinator to really check if we understand and to repeat. Could you just explain that? How do you know whether someone understands or not?
Well, after the patient initially gets their diagnosis, I would speak to them and say, right, did you understand everything that was told to you today?
And what do people normally say?
They go, I got 2% of it, and 98% I didn't hear, because they heard the word cancer. And unfortunately, that's why I feel like people, I would do a follow-up call the next day as well, and we go through the whole meeting again. And I'd say, so tell me exactly what you understood from yesterday, and then I'd start from there, and then we'd build on it. I'd ask patients if they use the internet, if they use technology like that, because there's great websites out there.
One website that I think is marvellous is Beyond 5, www.beyond5.org.au. And the other thing I mention is Cancer Council Information and Support Line 13 11 20. I mean, they're incredibly helpful. Look, before I let you go, Susie, is there any other change you would like to see? You've mentioned having specialist head and neck cancer nurses in a network, being able to share information by telehealth or even by conferences or special training. You've mentioned the innovation in surgery with the robot has been very helpful for those who are eligible for it or who have access. Is there anything else you'd like to add?
I'd like to that patients have a better plan when they're finished their treatment, their initial treatment. Their initial treatment can last from 6 months to a year. It depends on what treatment people are getting. But I'd like them to have a plan when they leave here, say from 1 to 5 years, and then after 5 years they get a different plan. So they have all the appropriate numbers. They know when they're coming back for scans. They know who to call if they can't come for follow-up. It's very important that patients come for follow-up. They've done all this hard work with this complex cancer, and then if they get lost to follow-up, it's very hard, and especially for the regional remote patients. So I think we need coordinators, nurses like myself, to keep them in the loop, keep them coming back.
Susie Flynn, you've been fantastic to talk to, and I just have to share with our audience that when I was having chemo, and I have very, very deep veins, we'll do a close-up on my hand later, after a number of people had tried to get the cannula in, they called the master, they called you, and you came in and you got it straight in. So I will love you till the day I die.
Thank you, Julie.
Thank you. And Susie Flynn, nurse coordinator, part of our video today on innovations in relation to surgical care for head and neck cancer patients, and we're about to meet a terribly important member of the team, speech pathology. Just come back in a sec.
Head and neck cancer, treatment innovations, improving survival and quality of life. Providing up-to-date, evidence-based information for everyone in the head and neck cancer community. Presented by Julie McCrossan, a head and neck cancer survivor. Media production by Daniel Taylor at Inside IT. Celebrating World Head and Neck Cancer Day, 27th of July, 2020. Innovations in surgery, radiation therapy, chemotherapy, immunotherapy, dental care, managing distress and recovery, managing mask anxiety, remove the mask research, Aboriginal and Torres Strait Islander patients, family and community. Discussions of innovations that are improving survival and quality of life for patients with head and neck cancers. The 2020 Head and Neck Cancer video series. Presented by St Vincent's Hospital Sydney, the Kinghorn Cancer Centre and St Vincent's Private Hospital Sydney.